Hi, I'm Ralph Preston, and every Tuesday, but today is Monday. Normally on Tuesday we have our Recovery in Science Zoom meeting. Today we're doing it on Monday, and we have special guests back for the fourth time, Dr. Samantha Amadeo, and I always like her presentations. They're simple and clear and informative in lay terms so we can all understand them. We've also got at least two people here who I hope will, or I'll call on later to talk about their AFO journeys. And we're going to talk today about AFOs, which is a very broad subject. And we're going to see if we can provide some good information and clear up any misunderstandings about them. And so that's kind of it for me. You got most of the content. We're going to do a little, Dr. Sam's going to do a little presentation, and then we're going to open it up for discussion. However, all of us feel that, Dr. Sam and I both feel like if you have a question, feel free to jump in even during her presentation. So there you have it. Dr. Sam, thank you again for number 4, and I hope we can do more in the future, and take it away.
Hello, everyone. Always nice to join you guys. I love being on Stroke Buddies, my number one favorite podcast. I'm going to share my screen so that we can see my PowerPoint here. Ralph, would you just be able to manage the chat and let me know if anyone pops in to ask a question?
I'll give it my best shot.
Perfect. Thank you. Okay. So AFOs 101, really just a simple understanding of really what they are, why we need them, how we can progress them, and any misconceptions that we have along the way. All right. So we're basically going to go through a little bit about me, and then again, understanding what they are, common uses for them, all of the different components that we can add on to them, and then our misconceptions. And really, as we go through those uses and the different components, we'll touch on what the benefits of those things are. So, just a little bit about me. I'm a physical therapist and I have my board certification in neurologic physical therapy. I have experience across a bunch of different, I guess, settings, including the hospital, rehab, pediatrics, research, you name it, I've been in it. And I also act as a mentor and a teacher. I've had many students. I teach other physical therapists and for them to be able to get their neurologic specialty as well. And then I educate through my Instagram and my Facebook post as well. I created NeuroThrive, Neurologic Physical Therapy and Wellness. It's my neuro PT practice where I provide both PT services and online virtual exercise programming and rehab coaching. You'll just have to forgive me. I have a little bit of a stuffy nose today. Okay. So AFOs, what are they? AFO itself stands for ankle foot orthosis. So there are different types of orthoses. So you can just have a simple insert orthotic that the typical person may have for maybe having flat feet. Or you could have a pretty significant orthosis that's considered like a HKAFO, which is a hip, knee, ankle foot orthosis that goes all the way up to the hip. But depending on your deficit, the type of diagnosis that you present with, you could have from the least restrictive to the most restrictive. But AFO, the ankle foot orthosis, is typically the most common one that we see prescribed to people who have had strokes. Now, even though it's just at the ankle and foot complex, this type of orthosis really does support the entire lower body to improve function. And that doesn't just mean I wrote function there and not just walking, because we typically think of it as to help us with walking, but the AFO can help us with balance. It could also help us with So balance during walking, balance in standing, during certain transitions. So the AFO does provide more support to us than just our typical walking. However, typically it's prescribed for things like if you go to your doctor, if you're with your physical therapist and we're noticing weakness in the foot, or well, within the ankle, where like you have a drop foot, where we have some knee buckling, instability in the ankle. So, are you rolling your ankle? Are you placing the foot down incorrectly on the floor? That's putting you at a higher risk of rolling your ankle. Um, spasticity. So, if we have any higher tone in our uh, ankle muscles, that's causing a clonus or pushing our foot right into like plantar flexion, we have a contracture, something like that that's due to higher tone, we can help by putting an AFO on someone to reduce the issues that are coming along with that high tone and spasticity. And then it also can be prescribed for people who have decreased sensation and proprioception. So commonly people who have like diabetic neuropathy, they can have an AFO because they have weakness, but also there's a loss of sensation where you don't really know where your foot is or your ankle is in space. So the AFO kind of protects it and puts a shell on the foot so that we're able to place it down better and that we protect the ankle and the foot from injury. Now, I have some pretty big um, charts that you'll see on these next two pages. Um, well, actually, it's the same page. Sorry, I must have doubled it. Where these are different types of AFOs that you may have had prescribed to you or you may have seen before. So the most common one that's typically prescribed or used, you can get it over the counter. It can be either plastic or carbon fiber. So it almost looks like similar to this, but it maybe doesn't have all of this bulkiness to it, is the posterior leaf spring. Now, this specifically just helps with dorsiflexion. So it's really just to support the foot from dropping. It's not very restrictive because it doesn't really have a lot of covering around the ankle. It's really just one long piece behind the calf that will help with dorsiflexion. Some of these as well, if it's a specific type of material. So sometimes our orthotists like to prescribe something that is carbon fiber because what the carbon fiber does is it's an energy storing material where when you bend the carbon fiber, it acts like a spring and it could push you and give you a little bit of a push off and a little more power when you're stepping forward. So not only does it help with the weakness, but it'll also help with a little bit of speed and power as you walk forward. This is something we also use when we do like trial devices. So if any of you were in acute rehab or maybe in your outpatient therapies, your therapist maybe is like, well, maybe I'm thinking an AFO would be good for you. They may just pull one of these out of the closet, strap it on your foot, and see how you do with it. And then you go to get a custom afterwards, which is particularly fit for you. Then we have things like a semi-rigid AFO, which we can have a little bit more, these are more like your custom ones, where we're able to really customize how much range of motion that we put into the ankle joint itself. So either we can make it a little bit more dorsiflexion, we could let it drop a little bit so you have a little more control. So we get a little bit more like customization with something like this. And also if people have mild spasticity, so for something like a posterior leaf spring, there's a little bit too much flexibility for someone who may have spasticity. Well, once we get more into a rigid type of an AFO, we're able to control and hold the ankle in more stiffness, more stiff range of motion, where spasticity won't really be a problem. Now, a solid AFO is exactly what this is here. There's no joint at all, so you can see the differences between these two, right? And this one even, I mean, that's really flexed forward. But see how this one here has a joint where it could bend and flex at the ankle. This one doesn't, right? So if someone has a solid AFO like this, the length of the foot plate is the entire foot. So the whole foot is being helped. We have help on the sides of the ankle, which will help with this movement at your ankle so that you don't roll if you need a little bit of medial lateral support. And it's holding the foot in neutral ankle dorsiflexion. So there's no way of getting any plantar flexion or any dorsiflexion here. You're just stuck in neutral, which is why we call it the most restrictive, because we really don't have any range of motion at the ankle or the foot here. Very, very good for people who have severe spasticity, severe foot drop, poor proprioception, the highest, the worst of the worst type of ankle foot impairment, so that we can protect them and provide them with the ability to walk, right? Because if they didn't have something like this, then they're going to be at a higher risk of tripping, higher risk of falling, higher risk of injury. So this can give a lot of independence to someone who has severe deficits in the ankle and foot. Versus if this is made, say this is made custom, right? You get this made and you're in the early stages after stroke, 6 months, right? 6 months to a year, you start to see some really good improvements. You're starting to get your tones going down, your strength is coming back. We have a little bit better control. Your orthotist can actually take this, chop it at the ankle, and create something like this that's an articulated or an AFO that has a joint at the ankle, where they can modify and customize how much range of motion you're allowed at the ankle, so that you can get a little bit of plantar flexion, you can get a little bit of dorsiflexion and actually work those muscles versus being stuck in this rigid position of dorsiflexion neutral. Okay. So that's the next one, the hinged articulating that I was going to explain, where it's really a customized range of motion AFO, where the PT and the orthotist should really work together to figure out what is the best for you to be able to have how much range of motion. And it can be easily modified by either tightening or blocking the amount of range of motion. And you can even have, so say you are pretty good with your, um, well, we could go into this a little bit more when I go into the different types of components that we can add to an AFO, but we can even restrict plantar flexion, but also give you enough dorsiflexion. So say, for instance, we're not really worried about knee buckling when you're walking, but we're worried about you catching your foot when you're doing, when you're picking your foot up to walk, like during swing phase. Then we could resist plantar flexion so you don't drop down and have a foot drop, but we could give you more dorsiflexion so that you can actually get some nice push off. Or you could actually maybe stand up a little easier when you're standing up from a chair so that your knee can go in front of your ankle. So there's different things that you can really customize with a hinged AFO. Now, a ground reaction AFO or a floor reaction AFO, we call it a FRO. These are really cool. So I like these, and I feel like they're almost like a hidden secret. And what it basically is, it's an AFO that also has a component on the front of the knee, front of the shin. So you can see it here. I mean, this is really bent forward, but you can see that this piece here is as if we had a shell or a block at the front of the knee. And what this does is when the heel hits the floor, it gives a little bit of extra force backwards at the knee. So when people have knee buckling, sometimes if we add a front shell to the AFO or a front block to the knee, we're actually going to prevent knee buckling. So that's a really nice way that we can control the knee with something at the ankle. So even if you don't have an ankle problem, but if we have a knee buckling problem, we could use an AFO to control the knee. So sometimes you don't even have to have an ankle issue, but if we add something like this onto an AFO, we can help control and improve the instability at the knee. Any questions so far on the types? Are there any types that any of you have or have used in the past? Good or bad experiences with them? Oh, I see what I did here. I'm going to unshare my screen. I didn't take the right.
We got a question. Are people normally aware of the term AFO or spasticity or dorsiflexion or plantarflexion? I can kind of answer that. Some
Go
are,
ahead, bro.
some aren't, but go ahead, Sam.
I would say if you're in your, am I still screen sharing? I'm not still screen sharing, right?
No.
Okay. If you are in physical therapy for a long amount of time and you have worked with your physical therapist and they do a good job and your doctors are doing a good job at educating you, you should have a good understanding of these terms. However, some people don't, and there are 5,000 things that you learn from all of your doctors and your therapists. So it may have been mentioned to you, but you just don't remember, type of a thing, if that makes sense. However, I can go into a little, would anyone like me to go into the what dorsiflexion and what plantar flexion are? Would anyone feel like that would be helpful?
It would be really helpful to me just to see by yeses or nos from the group of whether these are terms that are like normally within your way of thinking or not. Like the idea of AFOs, is that normally within your something you know about? Like literally that term?
That term.
Well, this is a fairly educated group, but we could really quickly ask, does anybody come here today not knowing what an AFO is? Okay. Julie is not a stroke survivor, which is fine. She's welcome here. But nobody else raised their hand. So
Oh,
most
Penny.
everybody's heard of it. If they haven't been prescribed one, once you get involved in a stroke survivor community, we get a lot of questions about them. Other people are always mentioning them. So I think that's one you learn pretty quick. Spasticity also, dorsiflexion and plantarflexion, maybe a little less than the others, in my opinion, just from um, what questions people ask and what they post and when they say, what's that?
Yeah, so typically if you are a stroke survivor or you have worked with stroke survivors before or anyone in the neurologic field, or if you've just seen people on the street with an ankle brace, it's probably an AFO. If it looks like this, if it looks like that plastic, that like whitish, clearish looking plastic goes on the back of the ankle, that's really an AFO. It's just the term of what that brace is. And it's prescribed because it really is a custom type of a brace for people who have neurologic deficits. We'll see kids wearing them if they have cerebral palsy. So there is a huge use of this type of a brace for just people in general. But it is a very common tool that we use in physical therapy. So it typically is a very common thing that people within the community know what it is. Also with dorsiflexion and plantar flexion. So let me just show you quick with my feet. You're going to see my little puppy in the back. So when the foot is pointing down, that's plantar flexion. When the foot is pointing up, that's dorsiflexion. So in order for us to clear our foot, what happens is typically in stroke, there's a weakness at the ankle here where the front of the foot just likes to flap forward. So if the person tries to take a step, the foot will drag on the floor. So they don't have dorsiflexion. They don't have the strength there. So the foot drops into plantar flexion and they have a drag there. Okay. And then also dorsiflexion is very commonly needed for this part of walking. So when your foot's at the end, to be able to stretch forward like this, or else you'll have a very short stance and have to like lift like this. But if you're able to get your foot really stretched forward, and then you'll need plantar flexion to push off, pushing down like that. And then people with There are tone issues following stroke. I'd probably recommend, Julie, if you're interested, rewatching our talk on tone, right? Ralph, that's definitely on your page somewhere,
I can,
where I go into the descriptions of what tone is following stroke. Um, like what, well, because everyone has tone. It's really the resting contraction of a muscle where the muscle itself just always has a little bit of a contraction in it, but following a central nervous system injury, either that tone can be too high or it could be too low. So when we see flaccidity or paralysis, it's usually very low. Um, versus a higher tone, it's very, very tight and we can't really get range of motion. And spasticity is more of like it's a velocity dependent type of high tone, where if we try to stretch the muscle in the opposite direction, it fights us back and pushes in the opposite direction. So you'll feel a little bit of restriction or a fight from the muscle. So for instance, if I try to, so my bicep is here, for my bicep to do its job, it's got to bend. If I want to stretch it, I would pull it in the other direction. As I'm pulling it quickly there, I'll feel a little tension where my arm wants to pull this way. There's also a clonus, which is a beating of tone. So if you stretch the ankle, you could get the foot almost beats back at you like this. So these are all things that can limit someone in their walking. I see Jeremy has his hand up. Go ahead, Jeremy.
Hi everyone. Um, I was just looking. I'm on AFO number 2 since my stroke. Both custom. They put the whole stocking, the casting. Found it weird when that happened. But I was kind of hate my AFO. I have a love-hate relationship with it, but I know it's needed. But I was wondering how to ditch it permanently. I know I need to get my ankle stronger.
Yeah, so we'll go through that a little bit at the end, where once I go through all the different types of components and stuff, I'm gonna go through a little bit about like how we can progress from one AFO to the next and then progress off of it if it's possible. And then a couple of other misconceptions as well. So stay
Okay,
tuned, Jeremy.
will do. Thank you.
I see Penny Owen Thompson wrote, I've never used an AFO. I have worked hard at my recovery. I'm able to walk without any aid at all when I'm at home. When I'm out in public, I use a cane. My last bit of recovery is my toes on the left are still up in the air. Would you suggest an AFO for that? Not necessarily. So an AFO it would be probably too restrictive for you. Um, if your toes are up in the air, it may be a little bit of a tone issue. I would probably have to dive a little deeper into that, but AFO itself would probably be too restrictive. So too much help for you. When I say too restrictive, it's giving more help. And now Polly says, I
braces are
started.
good for built. Sorry.
Go ahead, Ralph.
Sorry. No, I was getting a video for Penny and I didn't realize the audio would come up.
Oh.
Sorry.
And now Polly writes, I started with the PLS or posterior leaf spring and then got a custom articulated. Since 2019, I've had a custom carbon fiber with various amounts of ankle support, including my current one with the buttress. Yeah, so it's nice. Polly has kind of gone through all the different types, so she's been able to experience what it's like to have each
Look,
of
you're
these.
not actually going to get anything.
Sorry.
That's okay, Ralph.
All right.
So typically, a lot of the times we do start with the PLS, the posterior leaf spring, that prefabricated over-the-counter one, because it takes time to get a custom one, and we need to see what it's like and if you actually like it. So if you're benefiting from having something like that, that's when we go and we refer you to an orthotist, and they can do the custom one. And then as you progress, if you're able to progress, you can change. So, for instance, poly went from something custom articulated is more restrictive or gives more help to the ankle than a carbon fiber. So, the carbon fiber has more bend to it, it's lighter, it's a little bit more for people who are more advanced in their walking and their skills. So, she was able to progress to that, which is awesome. Ralph, do you want to show the video?
No, I was just
Sending it to her?
I have the exact same issue as Penny in that my toes were up. A lot of people have claw toes, and they're worse in my opinion, experience. But I dropped a video in the chat for you, Penny, about what I did to get my toes moving again and getting them back down looking like my other foot. I did it 11 years out, so it's a testament to neuroplasticity also. And I did it in about a month. Watching TV at night, no, didn't come out of my normal. I didn't spend extra time doing it.
Thanks, Ralph.
Sorry about the audio.
Oh, that's fine.
Not really. I'm a video technical director. Really like perfection.
Sometimes perfection is, I feel like people like when there's a little bit of imperfection. We become more normal to them.
Okay, well, this is a real normal meeting then.
There you go. Okay, so now these are the different types of components or the fancy little things that we can add on to it when you have a custom AFO. So some of these I already mentioned. So like the proximal shell, which just when we say proximal, that just means closer up in the body. Distal is farther away in the body. So if I'm talking about my distal upper arm, that's here. My proximal arm is here. So a proximal shell would be, so if you're looking at your AFO, distal would be like near the foot. Proximal would be by your knee and the top of your shin. So the proximal shell is exactly what I showed before, that it's kind of at the top part of the shin, kind of would lie right here. And that's to help with preventing the knee from buckling. And it's what we call in physical therapy, provides a moment or a force in the backward position. So pushing the knee into extension to help with that knee buckling. Trim lines. So these are things that can be easily blown out. We call blown out because what basically the orthotist does. Where the heck is that picture? Oh, there it is. This blown out is basically the orthotist has the ability to just heat the plastic. So these two are made of thermoplastic. It can be heated and molded and shaped. So what they basically do is they can add a trim line, which is basically a border to encase the foot or the ankle or wherever to provide more stability. So for instance, you see how this carbon fiber AFO just has really, it's like a line in the back. So it's only really just covering the back of the ankle, little tiny skinny. But the rigid AFO has that encasing, so it comes around the shin. So like, look at my big water bottle. The carbon fiber would be covering here. The rigid AFO, thermoplastic AFO has the plastic that comes around, so it's going to give more. So they can make that trim line bigger or smaller. Same thing with on the foot. So if you have your foot here, you can see here that the trim line or the border here is different on this foot compared to this foot, right? So they can really customize this to give you more support or less support. You can even see kind of on this outer part of this AFO that this outer part isn't that high, but this outer part is high. So this could be someone who has a lot of foot and ankle difficulties with like the inversion, eversion position of the foot, versus this person doesn't really have that big of an issue at the foot. So this may be someone who has inversion issues with the foot really turns in, while this person doesn't really have that big of an issue. Go ahead, Ralph.
Holly has some experience with add-ons and inserts, and we're going to call on her and Kevin and Judy when we get to the discussion, so she can add some real-world perspective to
Perfect.
Some of those add-on that you're talking about. So
Beautiful, beautiful. Yeah. So once we get into the indications, I'll call on you guys to give us a little bit of personal history. Now there's these different things that are called stops. They're a little bit more intricate to understand, but say we are trying to progress. We're trying to progress from something that's rigid to something that's articulated. We can customize how much range of motion you get by using things that are called stops. So a dorsiflexion stop is going to stop your foot from going into dorsiflexion. So these are really good for if you have poor control as you're in stance, and you can maybe have a knee buckle, so like something that a proximal shell would prevent. So it stops the foot from moving into dorsiflexion. So if you have bad knee control, we can do that using a dorsiflexor stop, which basically will just stop the foot from going into that range of motion. A plantar flexor stop will just stop the foot from plantar flexing, which is that drop foot position. So say we want to have range of motion into dorsiflexion, but we don't want to allow you to drop when you're walking, they can also reduce that range of motion by putting basically a block in that open joint. So those are some other customizations that, again, obviously, if we have an articulating joint, these are all things that we can add to it. Now, this was something I talked about with Ralph, and thinking of including. So there are these things in physical therapy world that are called clinical practice guidelines. So we call them CPGs. These are created by the Academy of Neuro-PT. They're made in all different types of physical therapy and orthopedics and cardiac, all these different sectors of physical therapy. But specifically, the Academy of Neurologic PT has different clinical practice guidelines that are big, giant, best evidence articles about all the articles about this one specific topic, where they give the best recommendations to us as clinicians. So because of how much this impacts and how much evidence that there is behind it, they were able to make a practice guideline for us physical therapists. And what it shows is is there really good evidence or bad evidence or just not enough evidence, like in the research, to support the use of an AFO after stroke? Now, FES is our functional electrical stimulation. So they also included functional electrical stimulation. So if anyone is familiar with like a bioness, where you're able to use electrical stimulation to help with dorsiflexion during walking, that's also included in here. But I just wanted to show you that this isn't just made up stuff. This is really, really well researched information that AFOs are very good. They are a very, very good thing for us to use. I know there is like so much negativity that comes from using an AFO sometimes, because we feel like we don't look the way we want to look, or we feel like we're using it when we should be stronger and not need something like that. But if we look at the evidence from all of this wonderful research that these really smart research physical therapists looked into, the best evidence says that physical therapists and practitioners should provide ankle-foot orthoses or FES to improve things like quality of life, walking endurance in chronic stroke, other mobility tasks. So that's like your transfers, stair negotiation, dynamic balance, so your balance while moving, and your walking speed. So it's proven that we can use an AFO to improve all of these things. So if you were to use an AFO, if you needed it, and we had your walking speed and it was slow, we would see significant improvement if we use, it's a very, very highly likely that we would see significant improvement in these things following use. And then functional electrical stimulation is also very good for improving strength and muscle activation, which shows that AFO isn't. So we're not going to get better strength using an AFO, because it's kind of making up for the loss of strength, right? So using FES, which is actual stimulation of the muscles, can improve strength and muscle activation in chronic stroke. So chronic stroke means anything after 6 months post-stroke. Now there's moderate evidence, which doesn't mean that it's bad evidence, or it doesn't mean that it just means that there's not enough right now for us to say, but it's not a negative thing. So we just don't know if it's very, very strong, if it would improve walking endurance in acute stroke. So this doesn't really apply to any of you. So this is really like in those first like 8 weeks following a stroke if it would improve walking endurance. So it doesn't really help you there. Or gait mechanics. So if we may still see some gait impairments following this, but in the basically showing carryover that if I gave you the AFO, if we took the AFO away, would we see improvements after we took it off? And it's saying that it may reduce stiffness in the ankle, but we're not 100% sure. Now, there is poor evidence that supports. So basically, there is some strong evidence that we can see that using something like this is not going to improve your tone and spasticity. It can improve it. It can improve your function so that your tone and spasticity doesn't get in the way of your walking or your function. But if I tested your tone and spasticity today, and then you used your AFO for a month, I'm not going to see an improvement in your tone and spasticity. It just will give you more function while you're managing that increase in tone or spasticity. Does that make sense to you guys? Do you feel like that's helpful to kind of see that this is actually embedded in research, that we're not just making this up? And now I can provide you all with, actually, I'm going to stop sharing my screen. I'm going to show you, I want to show you, because the ANPT, so the Academy of Neurologic Physical Therapy, does provide us some really great resources. Let me see if I can. I'm going to share my screen and show you guys this. This is the website, neuropt.org. I'm going to send it to you guys, where there is a lot of really good information for patients on here. So this is very much heavily for physical therapists, obviously, for us actually providing care. But do you see this tab? It says for patients. So all I did was I hit here. I went to for patients. Oops. Okay, for patients. Oh, never mind. Can I not click on it? Okay, I'm not going to click there. I'm going to click on, let me see.
I think you have to click on to the right when you go for patients. There was submenus.
Yeah. I'm just trying to find, there's a bunch of patient fact sheets that I'm trying to find.
Go down to patients again. Hover over it, now look in the right.
Yeah, it just brings me into consumer information. Oh, here, for information specific to stroke, click here. Let me see. No, this isn't what I wanted to show you. Let me see practice resources.
Tell you what we can do is you can find it on, I'll put it underneath the video when we post it.
Yeah, for sure. Because there's a lot of patient. Let me see. Yeah, I'll find it for you guys. But on here, there's a lot of patient fact sheets where it does a really good explanation of giving it in really good, easy terms to understand things like AFOs, things like spasticity, things like what you could expect in your rehab, things like that, where us as physical therapists could provide that to you. But if you just have access to it yourself, that could also be helpful. So I'm going to also share that with you after this, so that you guys can have more access to resources. But now that we've gone through all this, I'm just going to also share my screen again. And let's go through some misconceptions and questions that we may have. So the first question is, or misconceptions, is really, does everyone need one? And the easy answer is no. like in physical therapy, everything really depends because everything is very individualized. It all depends. So, oh, I'm going to put this over here. Oh, thank you so much, Polly. I see that you put the fact sheets in there. You're awesome. Thank you. So it really all depends. If you are struggling with things like I mentioned, you're having difficulty with knee buckling, you're having difficulty with sensation, you're having difficulty with tone when you're walking, um, foot drop, all those different things. That could be a consideration where it's like, maybe I do need one. And that doesn't mean that the question of, you know, do I need one? Does that mean you actually do? But getting that expert advice and bringing it up to either your physical therapist, someone like me that's a rehab coach, Ralph, who knows a lot about AFOs, people who are more experts in the field. Ralph, you're basically a physical therapist. um,
Thank you.
it
I don't know
it
about that,
takes
but thank you.
it takes, it's not going to hurt to ask and bring up the question. Even if you get to the stage of going to an orthotist and they're looking at things for you, say they even give you one and then you try it and you're like, I hate this thing. I don't feel like it's helping me. You just throw it to the side. Not a big deal. I mean, as long as it's covered by insurance and it's not very costly to you, it's not going to hurt you to try something out. Having more tools is better than not having those tools, right? Um, then it comes down to the idea of, can you progress? Obviously, in Polly's situation, she progressed. Many patients do because from the beginning of your stroke to where you are now, your deficits can look a lot different. You can make a lot more progress, or you could have something that happened to you in the meantime where, you know, you you maybe have now increased tone compared to before when you were had more paralysis in your leg. So it really depends where you can go from a less restricted device to a more restricted device to a less restrictive device. So there is a way that you can either progress or regress needing something like this, but using your physical therapist, using the tools that you have with your doctor, use of tone management medications, exercise, all those different things can help you progress through the stages of needing an AFO. Specifically, something that me and Ralph were talking about is if you the idea of needing an AFO for weakness is one thing, right? Because we have weakness and we want to be strong and protect the ankle, right? And give you the ability to have that improvement in function. However, if we refer back to that guideline, right, it's not going to improve strength. It's going to basically act as a brace. So if you have a little bit of strength under there, under the use of your AFO, it's good to walk and challenge yourself without it so we can actually improve the strength. If we have something there, so that you can eventually progress to not needing it. If we never work on it, we're never going to get past it. So you have to continuously try to challenge yourself and improve your strength safely and with guidance if you don't have the guidance so that you're able to progress. And that's only in some circumstances, but many circumstances it really does apply. Go ahead, Ralph.
A lot of stroke survivors do that at home, oftentimes barefoot. There's a lot of people who feel barefoot helps them in their recovery. They're not PTs, they're stroke survivors. And the reason that most people feel more comfortable at home and it's a good place to practice that is that you know where every chair and table and everything is, and in case you need to touch on to something, and it's a place you spend a lot of time, so you don't have as much of that fear factor as you have when you go out in public. Penny was saying she isn't wearing hers in public, but she takes a cane because she's still got some of that. Probably, I'm guessing. I haven't talked to her much. I'm guessing there's fear involved. It was for me. I dropped the cane when out in public when I no longer was afraid everybody was going to try and knock me over.
I love that idea because it kind of brings to light my very common discussion that I have with the difference between needing a device, because sometimes I do into assisted devices, but needing a device like an AFO or a cane for safety versus for rehab. So when you're with your physical therapist, when you're challenging yourself, when you're at home and you're in a safe environment where you can challenge yourself, you try newer things and you try to challenge yourself. So it's very common. So say you walk every day with an AFO, that you go to PT, or if you're working like an exercise program with me, that I say, try this without the AFO, try this without the cane, because we want to strengthen and challenge you. However, there's times that we may say, you need the AFO right now because we want to be able to do something that's more difficult. So, for instance, I have a client who she went out walking with her family. They went to the mall, they did X, Y, and Z, and she was going to be walking for a long period of time, which is going to make her, it's going to challenge her endurance, it's going to challenge her balance. She's in an unfamiliar environment. That's when we want to use the AFO and the cane or the more restrictive stuff so that we're able to do these bigger challenges. Because say you didn't, you'd probably be more restricted in your ability to do things like that. So in like real life, when you're going into like these scarier situations or more unfamiliar situations or more challenging situations, that's when you want to use your stuff for stability and safety. But when you're with your therapist, when you're in the comfort of your own home, something is a little less challenging and you feel safe, challenge yourself. There, as long as we do things safely and we plan them out, we can always try something new. Just really when we're trialing the difference between like using one and not using one, that I'd say that, when you're by yourself, we're really challenging other things like your endurance, your stability, you're walking on grass, you're walking on gravel. I wouldn't do that the first time that we're trialing no AFO. Does that make sense, guys?
Yes, we've also going to have a couple of other perspectives in addition to Polly. Kevin's got instability and lack of proprioception, and Judy got off of her AFO through walking around at home and strengthening her ankle, and then is now working with a physical therapist. I got to be careful not to say too much here because I know that she's working with a physical therapist and has chosen to go back on an AFO. But the way she put it to me was that she's doing it as a part of an improvement cycle versus dependency. And that's all I'm going to say because I don't know enough to talk anymore. And I'll let her tell her story later.
Yeah, for sure.
Sounds interesting to me.
Yeah, and you did mention there like proprioception too, Ralph. So proprioception is like our joints' ability to know where they are in space. So like basically if I close my eyes and I put my wrist down, I know my wrist is down and I don't have to look at it. I just feel it in my joint. Same thing with if I extend it. I know my wrist is extended even though I'm not looking at it, right? So some people lack that sensation in their ankle and their toes. So that could be a reason why that you have an AFO. Same thing with if you have spasticity or higher tone. You may not have weakness. You may have, usually people who have tone have a lot of like fake strength because the tone restricts them. So for instance, I work with a woman who has a lot of tone in her quad. I'm never worried about this woman buckling because her quad is tight. So it's really like she has strength there, even though it's like fake strength from the tone. So even if you don't have weakness, you can still benefit from an AFO to help with these other things. If you have poor stability in the ankle, which can happen if, you just have less proprioception. If you're just, I mean, just a person who has flexible joints, like hypermobility in their joints, people who just are more likely to get ankle sprains, that type of a person. So you really could have it for different reasons. And then the do I need to wear it all the time is it depends again. Kind of like what me and Ralph were saying, where once you have that conversation with, I mean, yourself, your family, your doctors, your physical therapists, whoever is in your care team about what is best for you, and really weighing the pros and cons of, do you need to wear it all the time? Or what can you do to supplement so that you don't have to wear this hunk of plastic on your leg all the time? What is, what really would work the best for you? Because there is no one straight answer of yes, you have to wear it all the time, or no, you don't have to. It all depends on the person. For instance, my brother, I don't know if I've told you guys before. I think I have. He has cerebral palsy. He has hemiparesis on one side. Um, and he presents with drop foot on his right foot. And he would definitely benefit from an AFO. He's 34 years old. And I see him with his drop foot all the time, but he's learned so well to compensate for it by lifting his leg up that really, does he need one? Not really. So, I mean, if you watched him, you'd say, oh, if we want to improve his drop foot, sure, let's give him an AFO. But he does fine without it. So it really all depends on the person and what your goals are as well. So my brother's not going to be hiking any mountains. He's not going to be walking. He's not a very motivated person. Sorry, Nick, if you're watching this. He's a couch potato. So he's not going to be walking crazy long distances or trying to get back to sports. So for him, the benefits of an AFO kind of don't outweigh the negatives of it. But for someone who really wants to get back into doing more difficult tasks, maybe having that little bit of help will push you forward. I do see that Jeremy has a question of, I'm scared of doing exercises at home that we do in PT. How can I get over this? So the exercises that you do in physical therapy aren't necessarily ones that you should be doing at home, because you have a physical therapist with you, a trained professional with you who knows how to guard and guide you the right way. That physical therapist should be providing you with safe home exercises that kind of reflect and support what you're doing in physical therapy, that are safe for you to do at home. So for instance, um, when I'm with someone in person, I never want to do the home exercise program that I'm providing to them, because that home exercise program should be something that they can do at home by themselves. Versus when they're with me, I'm challenging them where we're almost on the brink of instability, that they need my help, where they need my guidance, because then that's not skilled care. Then that physical therapist is not giving you skilled care if you can do those exercises at home by yourself. And that's just me on my soapbox. I could talk about it forever. But those therapists that make you come in and do your home exercise program for them, they're not doing a very good job. It's one thing to see if you can do them, because that shows, are you being a liar and saying you do an exercise program when you're actually not? If they want to check to make sure that you're doing them correctly is one thing. But for that to be your therapeutic exercises when you're there, no, 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 not good. They should be challenging you. All right, any other questions? This is open floor discussion now. So I'd love for anyone to share their experiences. Ask me as many questions as you like. I can be on here until, let me see. I have a patient at 1, so I could be on here until like 12:30.
That should more than do it, and we appreciate your time. We also have, I'm not saying Chris wants to talk, but Chris Morris here, he's somebody with extreme spasticity, hypertonicity, which to me is a indistinct word, misused word. So I know that Kevin would like to talk about his, and Polly, I'd like Polly to talk about her experience, and
Go for it.
Judy, I don't know if any of you, three of you's got to go. So if Judy or somebody's got to go before the others, let's let them go first so that we can hear from all of them. Anybody got to go? Nope. Who wants to go first then?
Can you hear me?
Yes.
All right. I've got a weakness in my is it TA muscle?
Your tibialis anterior, yes, the
That's
front,
the
the
one,
one
yeah.
that does the dorsiflexion.
if I'm sitting down, I can move it up and down, no problems. If I got weight bearing, then it's a bit weak. It's weaker. Now I play lawn bowls, which means that although I walk very poorly, I need to crouch down into a sort of a sort of squat almost in order to deliver the bowls. Could you do this with an articulated?
To do a little bit of a squat?
Yeah.
Yes, 100%. You could even do it with a carbon fiber. They're very bendy. Not
Yeah.
very bendy, but they do have give to them.
Right.
And something people do is if they do have a non-articulating AFO, when they have to squat or they're doing something like that, they just loosen the front strap, the strap that goes really right around the shin. You can loosen that a little bit so you get a little bit more movement at the knee.
Oh, okay. Right.
So sometimes we do that in rehab where, because it's a pain in the butt to take the thing off, put it back on, take it off, put it back on, is that if I'm working on like sit to stands or mini squats or something with them, I'll just loosen that strap a little bit so it gives them a little bit more range where they can dorsiflex, but also they still have the AFO on.
Now, can the TA muscle be strengthened, by exercises?
Oh, 100%. Yes. So there's the controversy of, are you able to improve strength, right, after stroke? If you're improving, if you're just a regular person and you worked on exercising and improving strength, you're going to get stronger. So the same thing can happen after stroke. Now, there's just an added layer of complexity where it leads to how much innervation or how much connection do you have from the brain to that muscle. We can change that and drive better connection through things like neuroplasticity. So if we're doing things at high intensities, if we're doing things very high repetition, if we're specifically working on the task that we want to improve in. So say you want to improve your dorsiflexion during gait, if we're actually increasing the repetition and intensity and working on dorsiflexion during gait, then you'll get better at that. All those different things to drive better connections nervous system wise. However, there is a layer of damage and injury there. So it's unpredictable how much neural connection we'll be able to get back. But yes, there is definitely the ability to strengthen.
Good, because I'm generally fairly strong apart from that muscle.
How do you mind me asking how far out from your stroke are you?
11 years.
Okay. Yeah, you could do it. Why not? Definitely. Especially if it's very specific movements that are perfect for you. 100%.
Is there any
Okay.
exercise that you can describe without it's
Yeah,
simple?
of course. So one of my favorite ones for two very easy ones that you can kind of incorporate into your day is hurdle negotiation and working on stepping up onto the stairs. All of those are going to improve your ability to lift the foot and clear during walking movements. So that's that task specificity where you could just sit there and move your ankle up and down, up and down, up and down. But does that really apply to walking? No, right? We want it to be during a walking motion. So when you're negotiating the stairs, if you're really working on trying to pick your foot up and then place it onto the step, alternating, going up the steps, that's a perfect task to try. Like either step ups and step downs or really going up and down the step. Same thing with like incline walking. So if you get on a treadmill and you try to do that, or you try to do a hill outside or a ramp outside, and then hurdle negotiation. So very easy, just throw something on the floor, like a pillow, a blanket, water bottle, something that you got to step over that's of a height that you can actually lift the foot over. That will inherently make you want to lift your foot up more to step
Yes,
over
I
it.
found that if I'm doing, say, marching on the spot, that the foot still points down a bit. So it's difficult to do both at the same time. Do the complication of marching on the spot, but also keep my foot up.
So you would just want to make sure. So what I would really look at for you is how many can you get before the foot starts to fall? So no, don't only go by the, okay, my foot is dropping. Is your foot dropping the whole time or is it fatiguing after a little bit? Because sometimes what we see is that in the beginning of an activity, the movement looks good. And then as you do 5, 6, 7 reps, the foot starts to drop. So pay attention to the foot a little bit more to see, are you able to do it a little bit better? And it could possibly be the height of the march, that once you're actually marching, you're bringing your foot up really high. So it could be too high of a demand on that muscle right now, versus if you did a hurdle, you can make it really low. That makes sense?
Yep. Thank
So
you.
so try that out and see how it goes, I would say.
Okay. Thanks.
Easy peasy ones that you should be able to do in your own home too.
Sure.
Okay?
Okay. Thanks.
Julie messaged me that Judy was raising her hand earlier. She's currently muted though, so I'll ask her to unmute and go next. Kevin and Polly, we'll get to you guys, so don't worry. Okay, Judy, I'm interested
Thank you.
in your
Thank you, Ralph.
I'm interested in your story, of course, because I'm interested in you.
Thank you. My stroke, Dr. Sam, was 3.5 years ago. And while I was in subacute care, I was fit with a rigid AFO. My weakness is on my left side. So once I got home, I discovered that I couldn't walk without it. And I said, oh, no, this will not do. So I approached Ralph with the idea of, okay, Ralph, how can I shed this AFO? And Ralph gave me some pointers and some ideas. And so for the next 2-3 months, I was religious about doing exercises, about walking as much as I could without the brace. And little by little, I got better and better and better to the point that I didn't need the brace anymore at all.
Beautiful.
Yeah. And I walked for probably 2 years without it. Now, during this 2-year period, especially toward the end of the 2-year period, my physical therapist started talking about an AFO. And of course, my initial reaction was, no way. But they were talking about a carbon AFO, which, as you've educated us, is a much less profile. And the indication was less cognitive load, which you understand what that is, and improved gait.
So let me just explain to everyone if they don't know, cognitive load talks about how much work your brain has to do to think while you're walking. So typically, when you're normal, you haven't had a stroke, you don't have any walking deficits, we don't think about our walking at all. Maybe I'm thinking about it if I'm walking on ice. I'm really being careful with where I'm stepping, walking on something slippery, but typically not thinking about it at all. When you have a stroke or you have something that's affecting your gait, you're going to think about your walking a lot more. So I'm sure what Judy was dealing with was that she was focusing on her walking a lot more. Now, your brain only has so much space or so much mental capacity to focus on different things at different times. This is like that idea of, can you walk and chew gum at the same time? So her physical therapist was suggesting that if she were to have a little bit of help at the ankle, it would free up some brain space so that she could focus on other things.
Yes, and I was to the point where I was staring at my feet all the time walking, and that was a habit that I very much wanted to break. So again, with less cognitive load, I can concentrate more on the quality of my walking, being able to stare or look beyond where I was walking. And so I have noticed those things. Now, I've since progressed and I'm trying the psionic sleeve, which of course is the FES. You're familiar with psionic neuro sleeve. So the AFO now, the carbon fiber, has become a backup to the psionic sleeve.
Beautiful.
Yes, And so I'm noticing great improvement in the quality of my walking, which was my goal.
Awesome. Awesome.
Thank you. So I really feel that I'm on my way to making some great strides.
Yeah, yeah. And I think something so important to just note that is that you were relentless in doing your exercises, you were disciplined, and you stuck with it. Because it sounds like it's easy and it can come from everyone, but having that discipline and motivation and sticking to it repetitive day after day and seeing, I remember you said little by little, not seeing, you're not going to see these big jumps. You know, people go into the gym, maybe right in the beginning, you see huge gains. These gains happen a little, we have to be patient with ourselves and stick with it because we know it works. So I compliment you, and I really wanted to make sure that I honed in on that for everyone else to say that is a huge piece in your success in your recovery is that you stuck with it and you tried things and you listened to the professionals that spoke to you as well, right? So even though at first you were like, I don't know about the AFO, you tried it and there was a benefit to it. So there is some benefit, and it is very good to trust them and work together because look how great you are now.
And I had a great coach. Thank you, Ralph.
Yes, Ralph too.
You're welcome.
Thank you, Judy.
You're a great student. You know, one thing about if you coach somebody, especially on something like an AFO, because you can get them in trouble. I mean, and I've never met Judy face to face, and that's a real disadvantage. But I knew she would listen, and also I knew that she didn't have. If you got like 10 degrees of supination, you can't use a method that we used. But mainly, I knew she would listen, and she did. I knew she was motivated, and you're absolutely right, Dr. Sam, about the whole persistence and repeating, doing the work. You don't get there without doing the work. And I love the language she used to me when we started talking about this meeting, which was that she felt that she was using it to progress on her own terms rather than be dependent.
Yeah.
So
Yeah,
that's
Yes, it's a tool. These
my
are
reaction
tools.
at first was, oh no, did I do something wrong that she's back on an AFO? So um, I'm glad it's working for you, Judy.
yeah, and the different types that something like a carbon fiber it's barely identifiable. It's so tiny in the back of your leg, and it really is very easy to conceal compared to, those big bulky white ones. Um, So it is something to try. And you know what? You could have tried it and hated it and said, nah, and we could figure out something else. There's never, we may just see a different length in time and improvement, or, just a different path. So we're lucky that we have all these options to try out. And as long as you're open-minded and you work alongside your therapist and people like Ralph and me and whoever is there to support you and help like make these decisions with you, then we can only see it as something that's positive, right?
And Polly has put in the chat earlier, she's got a carbon fiber one. She's able to wear it with normal shoes, I mean, without buying special.
Yeah, carbon fibers are
Two
nice and
different
thin. Let me show
sizes.
you.
We'll get to
Go
that.
ahead, Ralph. You can talk to whoever, but I'm gonna pull up a nice carbon fiber that's a little bit better than the one.
Well, I'm gonna let Jeremy go quickly, and then I'm juggling here, guys, and then we'll make sure that Kevin and Polly get their say
So
also.
you can see here, I'm just gonna show you guys quick. This is a typical carbon fiber where look how thin this is. It's almost like a shoehorn. It slides into the back of your foot, your shoe. Look how nice and thin this is. And this is the one with the fro, the front shield.
I, I, um, yes, I, um, uh, sorry,
Take your time, Rick.
Okay.
um,
Oh,
Okay.
I wear one. He can
Yeah.
type. I was
Yes.
going to ask him if he could type, but I didn't want to put him on the spot.
Which
Yeah.
kind?
Who, who, um, mm,
Carbon fiber?
yes, yes. Yep,
Have you
yep.
found it helpful?
Yes, yes. 1, 2, 3, 4, 5 years ago, stroke. Yeah.
Wow. What has it allowed you to do that you weren't able to do before?
Wide.
Drive. Well, because I'm sure that you're able to get out of the house more now by yourself.
Yes, yes. Well, why, wide, walking. Yeah, yeah.
Awesome. So you have a positive experience with an AFO.
Yes, 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 yes,
Good.
yes.
Very good.
I believe Rick has done some fundraising walks, like a 5K. Haven't you done a 5K, Rick?
Awesome.
1, 2, 3, 4. Yes.
That's amazing. Thank you for sharing.
Mr. Loomis has done a bunch of fundraising walks too. John, do you wear an AFO at all? When I'm trying to remember, I think maybe not.
I did originally up for the first 6 months, and then they told me to get rid of it. It went
We don't
from
want to
the
hear about John. John's just going to tell us that he walked 80,000 steps and make us all feel bad.
not today. No, not today.
Well, he had 16,000 the other day, and he often does, especially when you work. I guess you get a lot of steps in at work.
Yeah, I'm usually at 20,000 by the time I leave work at 11 o'clock in the morning.
That's crazy.
Yeah, well, crazy good. Anyway, Jeremy's had his hand up for a while, and then we got time. We'll get to Kevin and Polly and see if we have any time left or wrap it up. I want to make sure
Sure,
we
go
get
for it.
both Kevin and Polly. So go ahead, Jeremy.
Yeah, when I said I was afraid about the exercise, because in PT, sometimes they take up my AFO and wrap it with the ACE bandage, and we do some exercises with the ACE bandage. So I don't want to do those at home because I know it's gonna be weak or without the AFO. I know the AFO is semi-restricting a little bit. I have the hinge one.
So
So
what you
like,
could do, Jeremy, so what the ACE bandage does, I love to use the ACE bandage to see if someone will benefit from an AFO. So for me, I do a lot of home physical therapy as well. So I don't have like an AFO to just like pull out of a closet. So I bring an ACE bandage with me a lot of the time to trial. What you could do is the same thing that I told who was it before? Chris Moore. I told him about taking off that strap. Take off that front strap. So you still have a little bit of help, but you could just, loosen it a little bit so that the Velcro isn't as tight around the top of your shin. It'll give you a little bit more wiggle room.
yeah, because I bought like a cheap Rite Aid ankle doohickey, and I wear that inside the house. But in the house, I wear the AFO. I don't walk with the cane inside the house. But if I have the soft brace on, I need the cane. So
Yeah.
my goal is to get rid of the cane, but I know the ankle is still weak because at one time I had the soft brace. I tried going down the stairs and I felt the foot drop coming in. I was like, oh no, never mind.
Yeah, because sometimes what those ankle braces do at the store is they provide you with some medial lateral stability, almost like for somebody who had an ankle sprain, but they don't help with the dorsiflexion because they don't go far enough on the foot. So if you look at all the AFOs, they really have a foot plate that covers the entire length of the foot. The ones that like they'll say this is the length of your foot, this is your heel, it really only covers the heel.
Yeah.
So it's not going to help with that dorsiflexion. What you could do is there are on Amazon, you can get if you wear like a comfortable sneaker or like something that has a lace on it, you can get the one that attaches to the laces. It's basically the same size as the soft one that you would wear at that you would get from like CVS or something, but there's a string or a lever that basically like attaches to the shoelaces that lifts up the foot.
I know I know what you're talking about.
Are
Yeah.
you talking about like Flint Rehab and Sabo both have a like
Yes.
$100 solution that just got a couple strings and you can tighten them and loosen them? Is that what you're referring to?
Yeah, let me see if I can get a picture of it.
I have pictures, but I have to find them.
Yeah, I just Googled quick.
I got Flint Rehab
This
too.
is a Sabo step.
Yep.
But this is something, I mean, this one's like 37. That you could put these a little bit lower. This is probably what you're referring to, Jeremy.
Yeah, but
That was-
mine's have Velcro, not the string.
Not the strings. Oh, this is another one. See? What is that? 18 bucks. It's not going to give you the same stability and help that, you know, an AFO would because it's really only helping with dorsiflexion. But it'll give you, so this is a very common one that people say that they get from
That's
CVS,
what I
but it doesn't cover the front of the foot, so it's not going to give you anything. So anything like this, nice
And
and cheap. And you know what? Amazon, if you don't like it, you got 30 days, you return it.
and I
Just
assume,
one thing.
Dr. Sam, that the people with a lot of ankle roller supination have to be careful with that type because
Yes.
they do not provide any lateral stability.
Mm-hmm.
Okay, Kevin and Polly, want to make sure we get both of you in. Kevin, you want to go? Got to unmute.
Sure. Yeah, I mean, my stroke was what, over 10 years ago, 2015, January 17th. And
Birthday.
hemorrhagic stroke. And so I lost all feeling on the right side of my body. I still can't feel. Still have the same non-feeling I had on that day. So, you know, and I thought it was great, the coverage of it all and everything, but I used to be, hey, what can I do to, to get off of it and go away? And but uh, but like a year ago, I sprained my good ankle. I'm like, I live alone, but you know, I now I drive again. California has issued me a license again, and I'm driving. I have a car. I'm driving. I'm, you know, I'm getting back into life in a certain way. So what I end up doing is like I'll go to Costco or I'll go to Safeway and instead of using uh their automated thing, and I'll take a cart and I'll walk through Costco or Safeway or you know and I'm like sometimes I'll carry uh, uh, just a basket around with me at the grocery store. So and so and I wear my AFO every day. I use it because for safety reasons, and I and I just want to other people to know that yeah there's a and I've asked my um my therapist and my doctor, my recovery doctor, about you know switching off of it, and they're they're glad with what I do. I've got the rigid AFO. It works great. But I don't really know. I can't feel it, you know, where my leg is. I can't move it. If I take it out and see what's there, it does move. So I think people that some people have that problem, and I thought your coverage of it was great. So thank you, Sam.
Thank you, Kevin. I think you're a great testament to the other issues that can come along following stroke, not just weakness, right?
Yeah.
Where the proprioception is a huge, huge challenge for a lot of people when you have, I mean, sensation in general, but not knowing where your foot in space and making sure we're reducing injury. And when we have a stroke that's causing a hemiparesis on one side, we commonly always focus on that one side, but we have to take care of the other side too. Because one, we just got to take care of our body, but two, it's working extra hard, right? To give us that extra support. So someone like you would probably benefit from a lot of like balance, vestibular type of training where our balance that we have um, is provided by a bunch of different systems, our eyes, our inner ear, and our feet, our sensation in our feet. Since you don't have the sensation in the feet, we got to work on those other two systems, right? And then we also got to work on the balance and the stability in the other ankle to make us nice and strong, or the balance and stability at the knee and the hip, your balance reactions, all of those different things. So it's not necessarily like you're a lost cause because you don't have sensation and you have to use an AFO, but it's just a different type of care and rehab that we would have to provide you so that you can make progress, even if that means that you continue to use the AFO. So thank you so much for sharing.
Obviously, Kevin's point is not everybody can shed an AFO. I read somewhere that you can have good balance that would if you have any two of the three parts of your vestibular systems. I guess if I use it,
I think of it as like a stool, Ralph. It's a stool that
Right.
there's three legs and they all make up our balance system.
Well, but I read somewhere that
You only need the two.
well, you can get along with two. So if you don't have, Kevin doesn't have proprioception, then the thing to do would be to work on the other two. I believe his therapist has said he's not sure whether he'll ever be able to get off of it. And the mobility that it provides him, the fact that he's driving a car, hey there, dude. And nose bump, Kevin. I didn't have to. I asked him many times. He won't do it, but he came up and did it. He goes whenever I ask him to do it. He goes, "I'm not a dog. I don't do tricks." Anyway, it's a testament to Kevin's using it as a tool, like Judy's using it as a tool, but in a different way because he's now driving to Costco. He's now able to walk around. He's able to engage. He's able to socialize. And socialization is really, really important to us as human beings. And stroke survivors often don't get enough socialization due to mobility challenges. So, thanks for your perspective, Kevin. I almost said Kelly because I'm just going to say. So we'll ask Polly to give hers next. Combine Kevin and Polly into Kelly.
Well, I can kind of combine into Kevin because I also need to wear an AFO because of lack of sensation. I can combine with Judy because I need to wear an AFO so that I don't have to focus 100% on taking a step and moving safely. And let's see, who else? One thing Ralph kind of touched on was that like the Sabo step is not appropriate with higher tone. And I will say probably if it were just dorsiflexion, I wouldn't need an AFO. but the AFO I wear is mainly to control the ankle because of inversion and high tone. And that's a really tough nut to crack, as was evidenced by the clinical practice guidelines that, the AFO isn't. I will tell Kevin, I have combined wearing the AFO with FES, a ton of FES. I do FES several times a week, and that has helped with the return of some sensation after 5 years. And it has also helped with keeping some muscle strength, even though I'm wearing the AFO to ambulate. When I'm doing the FES, helping strengthen those muscles and maintain that brain muscle connection.
Absolutely, Polly.
Any
Absolutely.
suggestions on what to look for in an AFO when you're talking about high tone? Inversion is my biggest problem. And I'm lucky to have a great orthotist, and I'm actually getting a tab to help control the inversion in my heel in the carbon fiber AFO.
Yeah, so what I would say is typically what we say when there's a high level of spasticity or higher tone, we would want a more restrictive foot and ankle component, so like where the heel and the midfoot is. However, if you're using something that's carbon fiber, that really doesn't have those medial-lateral supports. So you'd probably need something a little bit more specialized, which would be probably more of a conversation to have with your orthotist. Because me as a physical therapist, I would just say a more rigid foot and ankle piece would be better for you. That's made out of a more rigid material versus something that's soft, because it's not, if it's very strong, your tone, we're not going to be able to, push against it. But again, I'm not a specialist in orthotics. The orthotist is. So you can bring that up to him and he can try those things. Of course, you are very good with all of these things. Like you're like spot on, and you're a really good student. So I think your input and bringing that to his awareness would be perfect.
My orthotist is female.
Oh, your orthotist, sorry.
Okay.
And they've been great with they have their own lab, and they've really been creative in coming up with problem solving for me.
Awesome.
Are they, Polly, did they make the add-ons that you have?
Yes.
Okay.
I was wearing an SMO, which is an additional what Dr. Sam was saying about the medial-lateral ankle support, that provides that medial-lateral ankle support within the carbon fiber AFO.
Yeah, so
But I had to
SMO stands for submalleolar orthosis. So it comes those big ankle bones that kind of stick out on the side, it falls right below that. So a very low profile AFO.
Mine was the supramalleolar, so
Oh,
it
okay.
actually went above the lateral
malleoli.
malleolus. It was below the medial malleolus, but
okay.
above the lateral.
See how nice it is that they can customize for you?
It's great. Except that was one case where I did have to wear a larger shoe. And because of the proprioception deficits, I really find it almost necessary to wear the same size shoe on both feet so that my right foot can give information about movement with the shoe to my brain that's missing from the left foot. And I wound up, because the shoe on the right was just so much too big, developing Achilles tendonitis in the right.
Yeah, yeah. So there it goes
So-
again, is we got to make sure we're taking care of the other foot and
Right.
um,
And so we learned that might be the best solution for me. So now we're trying a buttress,
very
an
nice.
extension on the outside of the shoe to help control the ankle.
Very, very. Yeah, anything with like what I would call like a lateral strut, those two on the side is very helpful.
I actually call mine Nort. It's actually on the outside of the shoe.
Of the shoe.
Mm-hmm.
Very cool, very cool. Got to just get you some nice high top Converses. Chuck
Taylors.
Actually, when I'm at home, I wear the high top Billy shoes,
Oh, nice. Okay.
and without the AFO.
Very cool. So the
Because,
Billy shoe
oh
is the one that
boy.
does the zipper on the top, right?
Yes, because if you've ever tried try to tighten the laces and tie the laces on the chucks with your foot not knowing kind of how it's fitting in the shoe and then having, no.
A mess. Yeah.
So I wear those around the house without an AFO because they provide enough ankle control
Oh, very good.
to walk safely. And I do have, after all sorts of everything, including still almost daily FES. Oh, I did want to ask about your brother. Has he considered FES? Has he considered the Bioness? Because Maddie Kneebank uses the Bioness and now can go hiking and can go, walking on paths and stepping on uneven surfaces.
He's just honestly, I think he's just kind of like happy with where he's at, where I've mentioned it to him before and he's just like, nah. So, I use him as my test bunny sometimes. I hate to use that term, but he really is. Where,
I use crash test dummy.
yeah, that's exactly.
I tell people
He
I'm
likes when I
willing to be
try
the
things
crash
on him.
test dummy.
So, I always mention
Well,
it. I'm like, it
If
would
he's
be good.
happy, that's what's important.
Yes, exactly. For sure. But thank you, Polly. I'm going to head out so that I'm
Yep.
not late to my next patient. If anyone has, so I reached out I gave Ada my phone number, not my phone number, my email, so she can reach out to me she has a question about her lower back. So I can target that again. So if anyone has, I'm going to just leave my email here.
Also, for everybody out in YouTube land, while Dr. Sam's putting it in the chat, all of her contact information, and I guess I'll need to grab that link that Polly so kindly found for us and drop the link about the patient resources
Yes.
underneath the video in the description. Typically, everything that we do and talk about, I try and provide the links later. And Penny, I messaged you that video that I dropped in the chat here, and directly, just in case you couldn't get it out of there or for whatever reason. So, what can I say, Dr. Except thank you.
You're very, very welcome. It's always fun to hop on here. If anyone has any other questions, reach out to me whenever. I gave you Ralph has all my information there, but you can easily find me on Facebook, Instagram, my email. I have my website now that's up that you can schedule a call with me on there if you'd like. And I would love to come back for another one. So we're going to get one on the schedule.
Well, we talked about, you dropped in the chat, cognitive load. I've got a lot of experience with that.
I think that would be a great one next because it
call
was
it
brought up a
running out
lot
of
today.
brain. Running out of
Yeah,
brain.
how we
The
could
other thing
target that.
about that is we use different parts of our brain that weren't meant to be involved
Yep.
in walking and such. So that, as a stroke survivor, that gives you an additional challenge to that whole cognitive load thing. And
Perfect. We got another one.
we'll let you go, and maybe you can grab some lunch before your next appointment.
All right. Thanks so
Thank
much,
you so
everybody.
much. It was
See you
great.
soon.
Thanks, Sam.
Thanks.
Do all you can with what you have. In the time you have, in the place you are, do all you can. Do all you can.